Okay. So, well, I'll continue, and maybe the camera will start working, but as long as you can see my slides, that's truly what's important. So good afternoon, and thank you for this opportunity to present. Today, I'm going to be reviewing the impact of COVID-19 pandemic on prostate cancer screening and surgery, highlighting some of the lessons that we learned from a regional collaborative in New York and Pennsylvania. So as we're all too familiar at this point, the COVID-19 pandemic has impacted every aspect of healthcare. If we remember back to the spring of 2020, during the immediate onset, non-essential medical care was delayed in order to prioritize patient, occupational, and community safety. Further, initial literature highlighted the potential for increased mortality in cancer and surgery patients, further prompting a critical appraisal of which patients should receive non-COVID care versus what could and should be delayed. And multiple papers have highlighted that localized prostate care, and specifically prostate cancer care, can safely be delayed. For example, this paper on the right was published from a group out of Wayne State, and using NCDB data, they demonstrated that there was no association between delayed surgery and adverse pathology or need for secondary treatment, which are reasonable surrogate endpoints for prostate cancer. Since prostate cancer can be safely delayed by 6 to 12 months without adverse oncologic outcomes, not only could these treatments be delayed, it additionally serves as a prime test case for the management of non-emergent surgical conditions during this time period. And for that reason, multiple societies suggested that prostate cancer generally could and should be delayed without a high risk of disease progression in this initial pandemic period. And along that same line, that prostate cancer screening and diagnosis should be suspended safely during the immediate pandemic period in spring of 2020. And as a result, and not unexpectedly, we saw a decline in the number of patients presenting with new cancer diagnoses, as demonstrated in this graph on the right. This is from a paper which used a national EMR database, and they evaluated the number of patients presenting for management of cancer during the first quarter of 2020 and compared it to the month prior, demonstrating a 50% reduction in overall cancer care. Further, they stratified this by cancer type, and prostate cancer care declined nearly 50%. And this was echoed by our own evaluation, where we were able to leverage a regional collaborative database to evaluate changes in prostate cancer care within our area near Prostate, where I was completing fellowship. And PERC, or the Pennsylvania Urologic Regional Collaborative, was founded in 2015 as a voluntary cooperative effort of both academic and community urology practices in southeastern Pennsylvania and New Jersey to focus on quality metrics for prostate cancer care. Currently, there are over 120 providers who manage men with prostate cancer or concern for prostate cancer across 11 different practice sites. Data at each site is collected by trained data abstractors via manual review of the electronic medical record. And this is truly a rich database which records every PSA, imaging study, biopsy, as well as the patient's demographics, surgical treatment, and associated complications and final pathology. Now, specifically with regards to looking at the impact of the COVID-19 pandemic on prostate cancer and prostate cancer care delivery, this database had a few key strengths specifically at this time. While not completely representative, it does cover both urban and rural settings, as well as academic and private practices, and it includes key regional safety net hospitals. Additionally, a few factors that were very important was it was relatively up to date. Most cancer registries provide data that is a few years old and additionally tend to be blinded to month of treatment, which is essential for this type of research. Further, because this was built to assess quality prostate cancer care, active surveillance is captured as a distinct treatment and clearly differentiated from lack of treatment, Despite these strengths, however, data abstraction was still impacted by COVID-19 pandemic. So while 7 out of 11 of these sites regularly provide data on prostate biopsy and surgery, only 5 were able to continue with data abstraction through the initial COVID-19 surge. So to look at the impact of COVID-19 on prostate cancer care, we compared patients during the lockdown period to the preceding 10 months. With the start of the pandemic or lockdown defined as care after March 13th, as this was when the national state of emergency was declared and that the American College of Surgeons recommended against elective procedures. May 16th was defined as the beginning of the reopening period, as this is when regionally Pennsylvania moved towards its yellow phase or reopening, where it lessened restrictions. We had 2 study cohorts, first patients that underwent biopsies, and then those who underwent prostatectomy. And this graph demonstrates the patterns of care from June 2019 to June 2021. And the green line represents weekly prostate biopsy volume, while prostatectomy volume was represented by the yellow line. The gray line shows population level mobility, which was obtained from aggregated cell phone data provided by Google. Lastly, the red shaded area represents the weekly new COVID-19 diagnoses within Pennsylvania. Overall, during the lockdown, weekly biopsies and prostatectomy volume decreased by 55% and 39% respectively, and these trends were contextualized by the concurrent drop in population level mobility and rising COVID-19 cases. Mobility rates dramatically decreased during the lockdown and interestingly corresponded more strongly with both prostatectomy and prostate biopsy volume than COVID-19 case counts. And so in the future, perhaps population level mobility may serve as a useful tool for hospitals and administrators for forecasting procedural volume. Additionally, we found that during the peak pandemic period, biopsy patients were younger with fewer COVID-19 risk factors, and that biopsies were consolidated to specific sites that continued to biopsy during these months. Additionally, there was no difference in risk factors for high-risk prostate cancer or time to biopsy or the utilization of MRI for those undergoing prostate biopsy during the pandemic. In the prostatectomy cohort, on the other hand, there was no difference in age or COVID-19 risk factors. And again, we saw large shifts in the distribution of practice site. And we look more closely at the site level variation. You can see that biopsy volume decreased from 6 to 79%, depending on the site. And prostatectomy volume ranged from a complete shutdown to an actual increase. Interestingly, there was no correlation between changes in biopsy and prostatectomy volume, likely demonstrating the different pressures placed on outpatient versus inpatient services at different centers. Additionally, we found that patients undergoing prostatectomy during the lockdown had similar preoperative workups with regards to time to surgery and MRI utilization. However, there was a trend towards selection of higher risk prostate cancer patients and increased utilization of neoadjuvant androgen deprivation therapy. After characterizing the general trends of the pandemic on prostate cancer care within PERC, there was one finding that we felt warranted further investigation and attention, and that was the sharp decrease in the number of Black men undergoing prostatectomy during the initial lockdown period. We felt that this initial analysis was very important given the known unfortunate history of healthcare disparities within the US. Overall, Black patients experience a 20% increased cancer-specific mortality compared to white patients. And in prostate cancer, which is the most common non-cutaneous malignancy in men, this trend continues with increased mortality and incidence. And while it affects 1 in 8 white males, on average, 1 in 6 Black males are diagnosed with prostate cancer. As you can see in this graph, over time, this gap between Black and white men has improved. And this is partially thought to be due to screening efforts. And further, studies have demonstrated that when access to care is equitable, these gaps can resolve. So this study looked at the absolute difference in prostate cancer specific mortality between white and Black men across different databases. Within the SEER database, which was used as an example of a representative data set, Black patients experienced an increased hazard of death from prostate cancer. This difference, however, resolved in data sets which include patients with a consistent level of care as seen within the VA or randomized controlled trial environment. Now, given this backdrop, we felt that it was important to further investigate the secondary effects of the COVID-19 pandemic within the so-called secondary wave, which was defined by the impact of resources on non-COVID conditions, particularly since, as we previously stated, there were recommendations to defer routine oncologic care. However, we worried that the secondary wave would be more pronounced in minority communities, as the literature has shown that these patients shoulder the brunt of the initial COVID-19 pandemic. For instance, in this paper published early in the pandemic, the authors demonstrated that Black patients represented 70% of COVID-19 patients and over 75% of hospitalized patients with COVID, despite Black patients only representing a third of the population in this data set from Southeast Louisiana. We saw this trend repeat itself across the US with reports of disparate COVID-19 cases, hospitalizations, and deaths. So to that end, we sought to evaluate the secondary impact of the pandemic on prostate cancer care, evaluating the effect of the COVID-19 pandemic in the PERC database again. So from this cohort, we looked at patients with untreated prostate cancer prior to the study period or the lockdown that were diagnosed within the preceding year. And then, as there can be seasonal variations in the rate of prostatectomy, our baseline cohort was for the same 9-week period from 2019. To begin, we looked at the patient demographics and clinical characteristics for patients with untreated non-metastatic prostate cancer during the lockdown, finding that Black men were significantly less likely to undergo prostatectomy, despite similar COVID-19 risk factors, biopsy Gleason grade group, and an actual higher pre-biopsy PSA. Prior to the pandemic, surgery rates were comparable between the two groups at 18 and 19%. And further, on multivariable analysis, adjusting for the presence of high-risk disease and age, we demonstrated that white men were 31 times more likely to receive surgical care during the lockdown than Black patients. To further assess the impact of race on surgical management during the pandemic, we fit an effect modification model with an interaction term between year and race, while adjusting for the disease risk category and age. During the pandemic, Black men with non-metastatic prostate cancer were 94% less likely to undergo surgery compared to Black men prior to the pandemic, and 97% less likely relative to white men during the lockdown period. On the other hand, the likelihood of surgery was not significantly changed for white patients during the pandemic, nor was there any difference preceding the pandemic. Lastly, we looked at the effect of the lockdown on prostatectomy volumes stratified by patient site of care and race. Each of these sets of bars on the graph represents a practice, with the first bar being for 2019 and the second for 2020. The dark blue area is equal to the volume of prostatectomies in white patients, while the light blue area represents those in Black patients. Lastly, the gray area represents the cases lost or the shutdown volume during the pandemic. Compared to before the pandemic, Black men experienced a 91% decrease in prostatectomy across all sites, while surgery declined only by 17% for white men. The degree to which sites reduced surgery varied substantially and ranged from complete shutdown to an actual increase in operations. Notably, sites that cared for a higher proportion of Black patients were those most impacted by the lockdown, with all sites experiencing a reduction in the volume of surgery for Black patients. Unfortunately, these findings have since been echoed by more data sources as they've matured. This paper that was just published 2 weeks ago reviewed the impact of COVID-19 on the incidence of localized and metastatic prostate cancer among white and Black veterans, and was a retrospective analysis from January 2019 to August 2021. And while they found that PSA testing and biopsies declined for all men, the absolute declines were larger among Black veterans, as you can see by the steep decline in the red lines compared to the blue lines for white men. This ultimately translated into a similar drop in the incidence of overall prostate cancer diagnoses, with recovery to baseline levels by the end of the study period. Most concerning, however, was that while the incidence of metastatic prostate cancer returned to baseline in the late pandemic period for white men, there was a significant increase in the incidence of metastatic prostate cancer among Black veterans, which nearly doubled that of white veterans. This brief communication provides an initial example of the possible stage migration that we'll see due to the decreased screening that was seen among Black veterans. And this is significant not just in prostate cancer, but across all cancers, as we saw cancer care delayed more significantly in Black and Latinx patients relative to white patients. So this survey, published just over the summer, surveyed over 1,000 US adults with cancer, finding that the COVID-19 pandemic was associated with disparities in treatment delays and adverse social and economic effects among Black and Latinx adults. However, it's very important to note that despite social and economic pressures such as job, housing, food, or childcare insecurity, Black and Latinx patients were much less likely to self-request delays in care, with 98% of delays being requested by the clinic or the physician. So taken together, these studies demonstrate the continued disparate impact of the COVID-19 pandemic and its secondary effects on cancer and specifically prostate cancer care. In our study, we showed that the large variations in prostate cancer care was driven by practice sites rather than patient biology, demonstrating how pandemic-related restrictions were unequally enacted. And this resulted in a profound racial disparity in prostate cancer surgery rates during the lockdown period. Changes in surgical volume were not solely caused by changes within an individual practice, but by systemic variations. In the PERC cohort, institutions that cared for a greater proportion of Black patients experienced more severe reductions, resulting in disproportionately fewer Black men undergoing surgical treatment across our study. This is notable since additional studies have demonstrated that the vast majority of care delays are secondary to provider requests and not that of the patients. In the Pennsylvania example, a likely factor was that 43% of the Black population resides within the city of Philadelphia, opposed to only 6% of the state's total white population. Since Philadelphia was hit harder by the initial viral surge, the impact was felt greater by Black men within our cohort. Further, multiple other studies have demonstrated this fact was amplified by pre-existing inequities in housing, employment, and insurance, which subsequently increased the exposure of minority patients to the virus and then restricted subsequent non-pandemic related care. Taken together, this demonstrates how existing structural and systemic racism exacerbates the effects of the COVID-19 pandemic on healthcare by disrupting availability of services and impeding care-seeking behavior and care delivery, truly exposing the fragility of our current healthcare system. Further, it's important to note that the PERC and the VA study include patients who have routine access to care or are already within an established practice. And I would anticipate that these findings would be further magnified in patients without pre-existing prostate cancer care. Studies have shown that, as we saw in the previous talk, that screening decreases are associated with the increase of distant or regional disease. And so the decreases in screening that we saw during the pandemic, and many of the gains, including the racial gaps that we have seen over the preceding decades, could be undone by the effects of the COVID-19 pandemic. Unfortunately, patterns similar to this are likely unfolding across medicine, and efforts are needed to recognize and offset the implications of our pandemic-related decisions by prioritizing care in underserved communities and increasing focus on patient re-engagement, with this truly coming from multiple sources within communities, physicians, and governmental agencies. Additionally, ongoing research in understanding the impact of the downstream and implications of our COVID-19 care delivery decisions on cancer care, and especially prostate cancer care, is essential in the years to come. I'd like to thank all my mentors and sponsors who made this work possible, and thank you very much for your time today.